of about four and mainly about four main endocrine disorders, that is Addison syndrome, Cushing syndrome, Hunt syndrome, and pheochromocytoma, right? And then you must know the basic investigation results of each of the conditions. And then you must know how to confirm those endocrine disorders. And then finally, you have to outline the basic management of each of the condition. And this is a sort of a basic structure of a adrenal gland, right? So you have adrenal cortex and adrenal medulla. Adrenal cortex can be divided into three zones: zona glomerulosa, zona fasciculata, and zona reticulata. Zona glomerulosa in the adrenal cortex, zona glomerulosa secretes aldosterone. In the other two zones, secrete androgens, adrenal androgens, and cortisol. Adrenaline and noradrenaline is secreted from the medulla. So basically, there can be problems with secretion of all these hormones. The hormonal secretion can be either low or high. Right? Suppose if the patient is producing excessive amount of aldosterone, patient will end up having primary hyperaldosteronism, that is Hunt syndrome. Patients can secrete excessive amount of serum cortisol, leading to Cushing syndrome. Right? From the medulla, if they secrete more and more adrenaline and noradrenaline, patient will end up having pheochromocytoma. Right? So if the adrenal gland fails, then there will be problem with the deficiency of hormones. It's mainly usually it's the adrenal cortex leading to Addison's syndrome, right? So it's very simple. Either the hormone secretion can be increased or hormone secretion can be low, leading to adrenal disorders, right? Yeah. So mainly the cortisol secretion is dependent on the hypothalamic pituitary adrenal axis. This is like school admissions. Okay. The cortisol secretion is depend on hypothalamic pituitary adrenal axis, right? Due to various stimuli, hypothalamus secrete CRH, that is corticotropin releasing hormone. So that will act on the anterior pituitary gland, and the anterior pituitary gland will secrete ACTH, which is going to act on the adrenal cortex, and that will stimulate production of cortisol. Right? So the secreted cortisol will have a negative feedback effect on the pituitary gland and the hypothalamus. But when it comes to aldosterone, it's mainly dependent on the renin, angiotensin, aldosterone axis rather than the hypothalamic pituitary adrenal axis. Basically, it's not totally dependent on hypothalamic pituitary adrenal axis. So even if there is a problem with the pituitary gland with reduced ACT secretion, still aldosterone can be secreted provided the adrenal glands are normal through the renin, angiotensin, aldosterone axis. Right. So if the adrenal cortex, the adrenal gland is not producing adequate amount of cortisol, basically, and other hormones, it is called adrenal failure or the Addison syndrome, right? So the adrenal failure can be either primary or secondary. Primary adrenal failure, there's something wrong with that gland itself, right? So usually it is due to destruction of the entire adrenal cortex, right? And they will have high ACTH levels because the serum cortisol is quite low. In addition, they will have high serum renin levels. Why? Because this again the whole cortex is disrupted. Both cortisol and aldosterone secretion is impaired. So the renin levels will be increased, and in addition, they will have high ACTH levels as well. Right? So secondary hypoadrenalism is usually due to a hypothalamic pituitary disorder. So this usually patients will end up having features of hypopituitarism, right? Hypopituitarism. So if there's a problem with hypothalamic pituitary disorder, then the ACTH level will be low. In addition, if the patient is on steroid for a long period, because of the negative feedback effect of steroids within the circulation, then again ACTH secretion from the pituitary gland will be affected. So leading to secondary adrenal failure. Okay? So you must know the difference between primary adrenal failure and the secondary adrenal failure. Primary adrenal failure is due to destruction of entire adrenal cortex, and because of that, serum cortisol, aldosterone secretion will be impaired. Whereas in secondary hypoadrenalism, the gland is normal, but the stimulation is not there from the pituitary gland, right? Due to either problem in the pituitary gland itself or due to long-term steroid therapy. In that instance, they will have low ACTH level, but usually their aldosterone activity will be, or the aldosterone concentration will be normal, as the adrenal gland is producing aldosterone through the renin, aldosterone, renin, angiotensin, aldosterone, adrenal axis. Right. So what are the causes for primary adrenal failure? So that is the destruction of the adrenal gland. Right. This can be due to autoimmune diseases. Can be due to tuberculosis, meningococcal septicemia, or it may be due to malignant destruction, amyloid deposition, or even due to adrenal leukodystrophy. Right? The common conditions are autoimmune diseases, tuberculosis, and malignant septicemia. Okay, right. So these are the conditions which are going to destroy the adrenal cortex. Right. Features of primary adrenal failure, so they will have all sort of weak symptoms, even in the secondary adrenal failure as well, right? So they can have loss of weight, nausea, anorexia, vomiting, diarrhea, constipation, abdominal pain, impotence, amenorrhea, and importantly, they can have postural dizziness and syncope, especially postural syncope, right? Due to postural hypotension, right? So in primary adrenal failure, due to very high ACTH levels, they will have pigmentation over the new scars, armor creases, and in addition, they can have buccal pigmentation as well, right? This is due to increased ACTH level. So ACTH will have melanocyte stimulating effect as well, right? So they will have no aldosterone, right? No aldosterone. So then they will have the salt and water can be wasted, right? So their intravascular volume will be impaired. Then they will have postural hypotension and features of dehydration, right? In addition, if it is something to do with autoimmune disorders, when you examine the patient can have features of vitiligo as well, right? Right. And sometimes patient can present with severe hypotension and dehydration due to either primary or secondary adrenal failure, right? And this is called Addisonian crisis. So if you do not recognize and if you do not treat these patients, right, then patients can actually die. So it is a medical emergency. Right? Usually, Addisonian crisis is precipitated by intercurrent illnesses where you need an excessive amount of cortisol for metabolism and other stressful conditions like accident and surgery. Right? So if you get a patient presenting with severe hypotension and features of dehydration and semi-consciousness and all that. So one thing you have to remember is Addisonian crisis. Right? So this will be supported by some other investigation findings. Right? So these are the investigations findings you can, you might or you can see with patients with Addison's syndrome. Right? They will have low blood sugar levels, low sodium levels, elevated potassium levels. Right? Even after hydrating them, they can have elevated calcium levels, elevated blood urea. Right? So if it is due to primary adrenal failure, they will have elevated plasma renin. Right? And then they can have features of anemia, and then the chest and abdominal radiograph, there may be evidence of tuberculosis, right? Right, apical fibrosis or even adrenal gland calcification, right? So they will have hypoglycemia, blood sugar will be low, they will have hyponatremia, hyperkalemia, hypercalcemia, hyperuricemia, and hyperenemia, right? And anemia, and then chest X-ray and abdominal X-rays of evidence of tuberculosis, right? So you must know. So if someone is coming with low blood pressure, right, when you do features of dehydration and even with hydration, blood pressure is not picking up, right? So when you do random blood sugar, capillary blood sugar, if the blood sugar is something like 64, right? When serum sodium is around 120 and potassium is 5.1, immediately that should click your brain, and you have to think about Addison's syndrome. So immediately you have to check whether there are any features suggestive of adrenal failure, like pigmentation and all that, and postural hypotension and all that, right? So that is how you have to suspect Addisonian crisis or Addison's syndrome, right? Good. So then, now how are you going to confirm the diagnosis? So this is extremely important about this, about synapton test and all, right? So now, for confirmation, random cortisol has a very little value. Now, if the serum cortisol level is less than 100 nanomoles per liter, in a sort of a stressful conditions, that is highly suggestive of Addison syndrome, right? So suppose now the patient has come with low blood pressure, dehydration and all that, and you found the blood sugar is low, and you suspect that the patient is in the Addisonian crisis, and again the sodium is low, and immediately if you do a random cortisol, if it is less than 100 in that kind of a stressful condition, right, that would support the diagnosis of Addison syndrome, highly suggestive, right? So if in that instance, if the random cortisol level is more than 550, the diagnosis is very unlikely, right? So that is again, now in your setup, if you are asked to answer a SBA type of kind of a question, there is no place for random cortisol, right? Basically, the investigation you have to suggest is short ACTH stimulation test. So that is again called short synapton test, right? Here you use synthetic ACTH. So you check basal serum cortisol value 1 hour after ACTH stimulation and 2 hours after ACTH administration. You check the serum cortisol level, right? So at the same time, you can combine that with basal ACTH assessment test, right? Suppose when you are going for a short synapton test, so on one particular day around between 8:30 and 9, you take a serum random or 9 AM serum cortisol sample, blood sample for 9 AM serum cortisol and ACTH, right? Then you administer ACTH or the short synapton preparation, right? And then you take another 2 samples for serum cortisol 1 hour after the ACTH administration, and then 2 hours after the ACTH administration, right? So if there is a good response, if the serum cortisol level is increased, right, especially to a level around 500, that is the test is negative. Doesn't look like it can safely exclude that the patient is having primary adrenal failure, right? Adrenal failure. And at the same time, when you give ACTH, if the serum cortisol level is not increased, right? Especially if it is less than something like 100 and all, so that could confirm that the patient is having adrenal failure, right? So in the normally in sort of exam scenario, you will be given the cutoff values, right? You will be given the cutoff value. You don't need to remember the cutoff values, right? So now suppose if someone is having inadequate response to ACTH, the serum cortisol has not increased, right? Serum cortisol is low even after administration of ACTH, right? Even after 2 hours. At the same time, when if you check serum ACTH levels, right? So they have inadequate response to synthetic ACTH, right? Serum cortisol hasn't gone up, and at the same time, patient is having a low ACTH basal value. That is done. The blood sample is taken before administering synthetic ACTH, right? So in that case, low ACTH and poor adrenal response, the problem is at the pituitary level. The pituitary is not producing adequate amount of ACTH, right? But if someone is having basal very high ACTH level and a poor response to synthetic ACTH in a short synapton test, then the problem is with the adrenal gland. Right? So that is how you are going to differentiate primary adrenal failure from secondary adrenal failure. So any question about that? Clear? Right? That you should know. So you should be able to, if you are given sort of an investigation kind of result, you should be able to interpret that if you are given with the normal values, right? So basically, there is little value for random cortisol. Confirmation is done with short ACTH stimulation test, right? You check ACTH basal level plus basal serum cortisol, and then you administer synthetic ACTH. You check serum cortisol 1 hour after and 2 hours after, right? And if there is no serum cortisol response, then there is a problem of cortisol production. So patient is having adrenal failure, right? Together with that, if the patient is having high ACTH value, basal value, then the problem is in the adrenal gland. If the patient is having a low ACTH value, the problem is at the level of the pituitary gland, secondary adrenal failure. Right. Right. So then after that, you do further investigations as indicated, right? So if the short synapton test is together with ACTH, if it says primary adrenal failure, you check adrenal antibodies. And then you can do test radiograph, like looking for pulmonary tuberculosis and malignancy, right? At the same time, even before going for all these investigations, you can ask for a ultrasound scan of the abdomen to look at the suprarenal glands, right? And if they are suspecting tuberculosis or malignancy, you can ask for a CCD chest and abdomen. So if you are suspecting problem with the pituitary gland, evidence of secondary adrenal failure, right? You can go for a MRI scan of the pituitary, right? So the further investigations, usually you can't jump and go for MRI pituitary gland or CVCT chest and abdomen, but depending on the circumstances, depending on the results of the short ACTH simulation test and ACTH values, you can choose these further investigations. Right. So how are you going to manage Addisonian crisis? Right. So this is a medical emergency. Right? So when patient present with anemia crisis in actual scenario, if this is sort of, if it is a sort of a life-threatening kind of condition, so you can't wait for all these short synec to arrange short synec and test and all that, right? You have to look after the patients. Uh, the not the diagnosis, but the patient management is the most important thing. So the priority should be given for patient management. So managing this medical emergency. Right? So you should hydrate the patient, right? So they don't have aldosterone activity. So patient is losing salt and water, right? So you have to immediately hydrate the patient. You can give normal saline 1 liter over 1 hour, and then several liters of normal saline depending on the response and other factors like evidence of pulmonary edema. You have to monitor the urine output. You have to look at the saturation, right? You have to look whether the patient is fluid overloaded and all that, and depending on that, you have to hydrate the patient, right? So in addition, immediately, so you can take a blood sample for random cortisol, and then you should start replacing glucocorticoids, right? So you have to give IV hydrocortisone 100 milligram 6 hours, right? So usually they have hypoglycemia. So you have to gain correct hypoglycemia with dextrose. So usually mineralocorticoid replacement with fludrocortisone is not necessary because we are using higher doses of uh, cortisol, right? IV hydrocortisone. So these steroids, they also have some sort of mineralocorticoid activity. So that is more than enough during the acute setup, right? So you don't need to give fludrocortisone during the initial management part. Right. So when it comes to long-term management, right? So you have to replace glucocorticoids, mineralocorticoids, especially, right? So glucocorticoids, the best medication would be hydrocortisone acetate, and it is not freely available sometimes, and it is a little bit expensive. It usually required dose is something around 20 milligrams per day. So early in the morning, you give 10 milligrams, and then 5 milligram is given during midday, and another 5 milligram is given in the evening. So if it is not available, you can use prednisolone or dexamethasone. Right? Mineralocorticoid replacement is done using glucocortisone. Right? So you need to replace glucocorticoids and mineralocorticoids. And the most important thing is you have to advise these patients, right? So these patients should always carry a steroid card saying the patient is on hydrocortisone or prednisolone or whatever it is due to adrenal failure, right? In addition, it is better to use a medical aid bracelet as well. Right? And in addition, we should ask the patient to double the dose during intercurrent illness, even if the patient is having chest infection or something like that. So again, we have to ask the patient to double the dose during the intercurrent infection, because as you all know, stressful conditions will require excess amount of the cortisol requirement will be raised during any on when there is an ongoing stressful condition, right? So if the patient starts to vomit, what is going to happen? So if the patient cannot retain but is taken orally, then immediately that patient should seek for medical advice and should get admitted for IV steroid replacement, right? So glucocorticoid replacement, mineralocorticoid replacement, and then you have to advise the patient, right? Okay. Any questions up to now about Addison's? Hello, can you all listen? Can you all hear me?
Yes, sir.
Hello.
Yes, sir.
Right. So there was some. So one person says, could you please repeat synecton test? So synecton test is the short ACTH stimulation test, right? And what you do is the synecton in synecton test, the preparation which you use is synthetic, right? On a particular morning around 9 o'clock, you take a blood sample for serum cortisol and ACTH, basal values. Then you inject synthetic ACTH and you check serum cortisol level 1 hour after the stimulation, 1 hour after ACTH dose, and 1 hour after AC this thing, right? So if the so I don't think I need to explain. So do I have to explain it again? So do I have to explain this synecton test again? Do I have to explain that? Yes or no? I think the explanation is adequate, probably. Sir, why Addison people have anemia? I'm not 100% sure, right? So when you go through these boxes and all that, those odd things, sometimes you have to remember, right? I'm not 100% sure why they develop anemia in Addison syndrome, right? Okay, there's a problem with voice, so that is something to deal with, some inherited problem of Zoom and all that, right? So why two blood samples are collected after administering synthetic ACTH, right? Okay, usually even one is enough. In our setup, it's a sort of an expensive investigation and all that. So again, one sample of serum cortisol is enough. So sometimes the recommendation is to collect two samples, right? So what you have to know is to how to interpret the results. Sir, could you please repeat the hydrocortisone doses? I don't know. Sir, can we use IM hydrocortisone in Addisonial crisis? Yes, if you cannot put a cannula in, right? If you fail, so you can try IM hydrocortisone, but in our setup, usually we put a IV cannula and we give directly intravenous hydrocortisone rather than IM hydrocortisone. Do we need to remember hydrocortisone doses? Can you please repeat? Hydrocortisone, so this is a sort of a medical emergency. So again, you must know the doses, right? So if you found a patient with Addisonial crisis, you can't ask the dose from the nurse, right? So medical emergencies, so usually what we give is either 50 or 100 milligram of IV hydrocortisone. In this setup, we will give 100 IV, 100 milligrams of hydrocortisone, right? So this is a short synecton test. This is done not 2 hours. It is done after 30 minutes and 60 minutes. Right. So additional features about Addison's, this eosinophilia and all that, apart from anemia, you have to read, right? Can anti-TB treatment cause sudden death in a patient with Addison's disease? I'm not sure. But now, if the patient is having a secondary adrenal failure, right? Secondary adrenal failure, then so if there's a problem with the pituitary gland, right? So if you do TSH, even the patient will have TSH, low TSH and low low TSH and low thyroxine level, free T4, free T3 levels as well. So in that instance, you can't straight away go and replace thyroxine. First, you have to replace, you have to give hydrocortisone and all that, and you have to look after the adrenal part before starting thyroxine. So if you give thyroxine, things can get really worse. How about immunosuppressive? So this is again now long-term things. Not you have to think about the patient developing addisonial crisis due to low serum cortisol level, right? Low serum cortisol level, because even in our normally, if you take a patient with pneumonia or a heart attack or whatever it is, right, with the stressful condition, as a normal body response, in individual serum cortisol level will be increased. That is why we are going to double the dose of cortisol during a stressful condition. So you have to look at in that angle in what is going to happen in normal individuals. So you mimic that by doubling the dose, right? So this is again not 2 hours. It is half an hour and 1 hour. So I think this long all sort of comments are coming up. So this has to be half an hour and 1 hour, not 2 hours, right? Right. Okay, can someone answer this question? Features that would suggest primary adrenal failure than secondary adrenal failure? So if no one is answering, I will move on to the next question, next slide, right?
Pigmentation is true.
Pigmentation, true or false?
True.
Vitiligo,
True.
true, because it's an indicator of that the patient is having fibrosis.
True.
True, because that is indicate that indicate that patient is having tuberculosis, right? History of meningococcal septicemia. True. Hypoglycemia.
False.
Hypoglycemia happens in both conditions, right? Elevated ACTH.
True.
Hypoglycemia is wrong. So hypoglycemia can happen in either primary or secondary adrenal failure. That could not suggest primary adrenal failure. Elevated ACTH.
True.
Low TSH.
False. False.
Normal response to long synapton test. So what is the long synapton test? In long synapton test, So you would observe the patient for a long period. So nowadays we don't do this long synectant test because we do ACTH. We will assess ACTH levels simultaneously, right? So because of that, we don't do the long synectant test. Right? In long synectant test, usually if it is due to secondary adrenal failure, right? So if you observe the patient's serum cortisol value for a long period, like 48 hours, then they will have a adequate response. After not after 1 hour, but after a long period, after 48 hours. Right? So that is called long synectant test. So in long synectant test, patient will have normal response if the cause is secondary adrenal failure, but no longer it is being done because nowadays we have facilities to do serum ACTH level. Right. Okay. So I will move on to Cushing syndrome. Right. So this is resulted due to increased fee-free circulating glucocorticoids. Right. And Cushing syndrome is basically we can categorize into two categories: Cushing syndrome due to ACTH dependent causes and non-ACTH dependent causes. ACTH dependent causes are pituitary dependent, that is pituitary gland secreting elevated levels of ACTH, that is Cushing's disease, and ectopic ACTH producing tumors, mainly CF bronchus or carcinoid tumors, or ACTH administration, right? But mainly it has to be Cushing's disease and ectopic ACTH producing tumors. So non-ACTH dependent causes are adenoma and adrenal carcinoma, glucocorticoid administration, and alcohol-induced and depression-induced pseudo-Cushing syndrome. Right? So they can, in those who are taking alcohol for a long period and those who are having depression can have features, clinical features of Cushing's. So that is called pseudo-Cushing's, right? Now, when you take adrenal adenoma and adrenal carcinoma, they are producing large amount of cortisol, but still, even with a large level of cortisol, the pituitary is not secreting ACTH, but still, because of the malignant properties of adrenal carcinoma and then adrenal adenoma, they will be producing more and more cortisol on their own, right? Again, with the exogenous steroids, again, that will act on the pituitary gland and the ACTH levels will be minimal. Right. So these are the clinical features of Cushing syndrome, right? So again, from second MD onwards, we learn clinical features of Cushing syndrome. Right? They will have weight gain, change of appearance, all central obesity, buffalo hump, and all that. They can have depression, insomnia, amenorrhea, or oligomenorrhea, poor libido, and all sort of clinical features. Right. So again, you must know the clinical features and clinical signs of Cushing's syndrome. So I'm not going to go one by one. Right. So again, there are certain clinical features that could direct the diagnosis toward a particular cause. Right? Suppose if the patient is having features of Cushing syndrome and pigmentation. So this is again seen only with ACTH dependent causes. So it can be either due to pituitary issue, pituitary gland secreting more ACTH, or it may be due to ectopic ACTH secreting tumor. Right? So Cushingnoid appearance can be seen with excessive alcohol intake and even in depression as well. So impaired blood glucose and frank diabetes mellitus can be seen in all causes of leading to things, but especially this is seen in patients with ectopic ACTH secretion, right? Again, hypokalemia can be seen with all the causes leading to Cushing's, but again, it is common with ectopic ACTH secretion due to a tumor. Hypertension is common with all causes. And if the patient develops severe virilization, that will be due to a adrenal, most likely to be due to an adrenal carcinoma, right? So you should read about the difference between hirsutism and virilization, right? Hirsutism can be seen in patients with all causes leading to Cushing syndrome, but virilization is particularly seen in patients with adrenal carcinoma, right? Hypertension, one with all causes. Hypokalemia, seen with all causes, but common with ectopic ACTH secretion. Again, blood glucose, diabetes, common with all causes. Again, especially seen in ACTH secreting, ectopic ACTH secreting tumors. And then pigmentation seen only with ACTH dependent causes. Right. So these are the features that would support ectopic ACTH secretion, right? One is unprovoked hypokalemia. So unprovoked means not by due to diuretics and all that, right? So that is if the patient is having refractory hypokalemia, if it is difficult to treat, right? And if the patient is having features of Cushing syndrome, the most likely cause would be ectopic ACTH secretion, right? So again, they will have a very short history. They will have pigmentation. They will have diabetes mellitus and the diabetes mellitus. So loss of weight related to the malignancy and all that, and they will have very high ACTH levels, right? So all these features would go. So again, diabetes mellitus, again, that can be seen in under other causes as well, right? But again, especially if they have ectopic ACTH secretion tumor, so the chances of developing diabetes mellitus is high, right? Again, pigmentation can be seen in patients with pituitary disorders secreting ACTH, but again, the pigmentation is more in patients who are having ectopic ACTH secretion, right? So out of all these features, unprovoked hypokalemia or refractory hypokalemia will suggest the diagnosis of ectopic ACTH, right? That you should remember. Right. So then, when you have a patient with suspected Cushing's, so when you do random blood sugar or fasting blood sugar or glycosylated hemoglobin levels, they will have elevated blood glucose levels, right? And in addition, when you do the serum electrolytes, they will have hypokalemia, right? Hypokalemia, right? So basically, so these patients will not come and tell you that the patient is having Cushing syndrome and all that, right? So usually these patients will have hypertension and diabetes mellitus in a sort of a given scenario. And when you examine these patients, they will have clinical features like Cushing syndrome. Like clinical features you have learned from your second MBBS days, like moon phase, right, and central obesity and all that, right? So when you examine these patients, you will realize they might the patient is having this purple striae and all that, and then you check for buffalo hump and all that. So the clinical features will be there, right? So in addition, when you check the patient's blood pressure may be on the higher side, right? So then immediately, so young hypertensive patient, so there are features suggestive of Cushing syndrome. So you have to think, immediately you have to start thinking about Cushing syndrome, right? So then you do the basic investigations, right? So then you will see the patient's blood glucose level is elevated, either there will be impaired blood glucose level, so the patient may be having diabetes. And then when you do the other basic investigation, you must realize the patient is having hypokalemia as well, right? So then when you suspect Cushing syndrome, so then there are screening tests. There are 2 screening tests you can do. So one is the overnight dexamethasone suppression test. So the other screening test is 24-hour urinary free cortisol excretion, right? So out of these 2, overnight dexamethasone suppression test is more convenient. You give dexamethasone 1 milligram at 11 o'clock in a particular day, and you check serum cortisol value at 9 a.m. on the following day. If the plasma cortisol level is more than 100 nanomoles per liter, the test is positive, right? So the screening test is positive. So you have to go for further investigations, because there may be false positives as well. So you have to confirm with other further investigations, right? So nowadays, this is the screening method which we use. We usually go for overnight dexamethasone suppression test. So otherwise, you have to do 24-hour urinary free cortisol excretion levels and all that. Then patient need to collect urine for 24 hours. Right. So the next step would be to go for low dose dexamethasone suppression test. Right. Patient is given dexamethasone 0.5 milligrams 6 hourly, 8 doses from 9 a.m. day 1. And you check serum cortisol on day 1 9 a.m. and serum cortisol on day 3 9 a.m. Right? If the cortisol level is not suppressed, you take it as a positive test. So positive test can be seen in patients with Cushing's disease, where there is ACTH secretion from hypersecretion from pituitary. In ectopic, ACTH secretion, adrenal adenoma and adrenal carcinoma. Right? In pseudo-Cushing's conditions, this test will be negative. Right? So you start with overnight dexamethasone suppression test as a screening test, and then you go for low dose dexamethasone suppression test. Right? So that is positive in Cushing's disease, ectopic ACTH secreting tumors, adrenal adenomas, and in adrenal carcinoma. Right? So then, if someone is having a positive over dexamethasone suppression test, low dose dexamethasone suppression test, right? To differentiate Cushing's disease from ectopic ACTH secretion, adrenal adenoma, and adrenal carcinoma, you go for high dose dexamethasone suppression test. where you give dexamethasone 1 milligram 6 hourly, 8 doses from 9 a.m. day 1, and you check serum cortisol level on day 1 9 a.m. and serum cortisol level on day 3 9 a.m. Right? So serum cortisol is not suppressed in ectopic ACTH secretion, adrenal adenoma, and adrenal carcinoma. Right? And the serum cortisol level will be suppressed in Cushing's disease. Right? This is because when you give a higher dose of dexamethasone, even though there is a problem with the pituitary gland and the pituitary gland is secreting excessive amount of ACTH, again, due to the negative feedback effect, that can be suppressed to a certain extent. Right? So because of that, in Cushing's disease, patient will have a negative high dose dexamethasone suppression test. Right? So in again, now the further investigations should be arranged according to the results of dexamethasone suppression test. So if the low dose is positive and the high dose is negative, then you have to think about Cushing's disease. Then you have to go to particularly do a pituitary MRI scan. Usually they will have microadenomas. So CECT will not pick them up. Even the pituitary can miss pituitary microadenomas leading to Cushing's disease, right? If we are suspecting adrenal adenoma or carcinoma, then we can go for a CCT abdomen, right? And if you are suspecting ectopic ACTH secreting tumor, so you go for CA bronchus or suspecting CA bronchus or carcinoid tumors, then we are arranging chest radiograph and CCT chest and abdomen. And nowadays people use MRIs on chest and abdomen as well. Right. So how are we going to manage these patients? Right. So whatever is the treatment option finally available, like surgery or medical therapy or radiation or whatever it is, number one is during the acute setup, before you go for a sort of a permanent solution like surgery, you have to control cortisol hypersecretion using medications. So the two medications particularly which we can use are metyrapone and ketoconazole, right? That those two medications will suppress the cortisol secretion from the adrenal glands, right? So if it is due to Cushing's disease, like a sort of a pituitary tumor, then we can arrange transsphenoidal resection, or they can be managed with external pituitary radiation, right? Medical therapy with medications like bromocriptine, right? And particularly in patients with adrenal carcinoma, we can go ahead with adrenal gland, surgically adrenal glands can be removed followed by radiotherapy. Right? So if it is due to ectopic ACTH secreting tumors, again with investigation, we should hunt and we should find the primary tumor, and we should remove that surgically, and we have to treat them followed by radiotherapy and chemotherapy. Right. I think I will answer these questions at the end, right? Okay. So shall I move on to hyperaldosteronism? Right. Now, hyperaldosteronism, it's again due to increased levels of aldosterone, right? So it can be either primary or secondary. Primary is due to increased aldosterone secretion from adrenal cortex. So this can be due to adrenal adenoma, that is called Cushing syndrome, or adrenal hyperplasia, right? Secondary causes may be due to adrenal artery stenosis and accelerated hypertension, right? In primary adrenal failure, adrenal hyperaldosteronism, they will have low renin activity, and in secondary uh, hyperaldosteronism, the patients will have increased renin levels, right? It is due to increased renin levels. So again, the same biochemical features may be there even in renal artery stenosis and accelerated hypertension as in primary hyperaldosteronism. Right. So again, so when to suspect primary hyperaldosteronism? Right. Especially when there is a patient coming with young hypertensive patient. Right? A hypertension in a patient with age less than 35 years, and when there is no family history of hypertension. Right? Not only Cushing syndrome, in those instances, you have to think about the other conditions, other causes which could give rise to sort of hypertension at a younger age, like pheochromocytoma, Cushing syndrome, and all that. Right? So accelerated hypertension. Now hypertension within a very short period with kind of target organ damages and all that. Right? So unusual symptoms like muscle cramps and weakness in Cushing's disease, Cushing syndrome is especially due to hypokalemia, right? Muscle cramps and weakness. And then resistant to common antihypertensive medications. And the patients requiring more than 3 medications to control hypertension. And in the presence of hypokalemia. So hypokalemia is the most important thing out of all these features, right? So resistant to common antihypertensive medications can happen with pheochromocytoma as well, right? Hypokalemia, muscle cramps, and muscle weakness, right, is usually indicating Cushing syndrome. So if you are given a history scenario with muscle cramps and weakness, then if the potassium level is quite low, it is more towards Cushing syndrome. If the patient is having hypertension, diabetes, obesity, and hypokalemia, right, and elevated blood pressure, you have to think about Cushing's. Right. So how are you going to investigate for Cushing syndrome or primary hyperaldosteronism? Right. So the basic nowadays, but the investigations which we do is plasma renin aldosterone ratio, right? Plasma renin aldosterone ratio. So they will have low renin level with elevated aldosterone and elevated renin aldosterone ratio. Serum electrolytes, again, they will have hypokalemia, and together with that, they will have increased urinary potassium excretion. So usually when someone is having hypokalemia, you would expect to see low urinary potassium loss. But in this instance, the urinary potassium excretion will be increased, and that is more than 30 millimoles per day in presence of hypokalemia. Right. Then to go for CCT abdomen and MRI or MRI abdomen to differentiate when you confirm the diagnosis of primary hyperaldosteronism, to differentiate whether it is due to adrenal adenoma from hyperplasia. You do imaging with CCT abdomen and MRI scan of the abdomen. Right. So if you find adrenal adenoma leading to primary hyperaldosteronism, you go for surgical resection. Right. If there is hyperplasia, the treatment of choice would be spironol factor, which is going to block the action of aldosterone. Right. Okay. Right. So then I will move on to the last endocrine disorder, which I'm going to, adrenal disorder, which I'm going to discuss today. The last one is pheochromocytoma. Right? So this is a rare tumor of sympathetic nervous system. And in 90% of cases, it is coming from the adrenal medulla, and that is called pheochromocytoma. So 10% of cases, this can arise from other associated to the other ganglia of the sympathetic chain. So that is called paragangliomas, right? In 90% of instance, it is pheochromocytoma rising from the adrenal medulla, right? Sympathetic nervous system tumors. So most tumors will secrete both adrenaline and noradrenaline, right? Will secrete both adrenaline and noradrenaline, right? So the large tumors, but particularly large tumors and extra-adrenal tumors, that is paragangliomas, will entirely secrete noradrenaline. So these are the clinical features of pheochromocytoma. So remember these features of anxiety, palpitations, tremors, sweating, headache, and flushing, especially, right? And tachyarrhythmias and all that. So those features will present intermittently, right? So they can come and tell you that patient will have intermittent palpitations. Okay? So associated with sweating, right? Episodic headaches and flushing. Right? So intermittent clinical features are highly suggestive of pheochromocytoma, right? Together with elevated blood pressure. In addition to that, they can have loss of weight, constipation of diarrhea, Raynaud's phenomenon, right? Chest pain, polyuria and nocturia, right? And importantly, these individuals have postural hypotension as well. Right? Postural hypotension aspect. Together with hypertension, they will have postural hypotension. This may be related to fluid loss and all that. Because of polyuria and nocturia, together with the sympathetic stimulation, they will have elevated blood pressure. But again, with the polyuria and nocturia, their intravascular volume will be depleted, and because of that, together with hypertension, they will have postural hypotension as well. Right? So in addition, they can have flushing, glycosuria, feverish kind of feeling, and importantly, capiolate spots as well. Right? This is again one clinical feature you should remember. Right? Capiolate spots will indicate if present is suggestive of pheochromocytoma. Right. So again, how are you going to investigate these individuals? Right. Now, in our setup, what we do in our hospital setup is 24-hour urinary VMA excretion. So we will miss more than 80% of patients with pheochromocytoma by doing this test because it's not sensitive. It's not sensitive, right? So nowadays, what we do is measurement of urinary metanephrine's excretion. Right? So if someone asks from you, this is the answer you should give: measurement of urinary catecholamine or 24-hour urinary metanephrine excretion. So that is the investigation which we do to screen or confirmed pheochromocytoma, right? So in addition, usually they have large suprarenal tumors, right? So sometimes even an ultrasound scan of the kidneys and suprarenal region will pick up the large adrenal tumors leading to pheochromocytoma. So you miss with the ultrasound scan, or for further differentiation, you can go ahead with CCTs of the abdomen. So management. So if you find adrenal tumor leading to pheochromocytoma, the ultimate treatment option is surgical resection. Now, these individuals should be looked after very well during pre and perioperative period. Right? And these patients need complete alpha and beta blockage with phenoxybenzamide. Right? So these individuals need alpha blockage before beta blockage. Right? So you cannot use propranolol as the first line medication to treat anxiety, tremors, and all that in patients with pheochromocytoma. Right? So you have to first block the alpha receptors before you go and block the beta receptors. Otherwise, you will block the beta receptors, but the alpha receptors will be in, right, and all the adrenaline and noradrenaline will go and act on alpha receptors, leading to a lot of problems. Right? So in addition, these individuals are volume depleted, and we should transfuse blood to expand the intravascular compartment during the perioperative period. Right. Okay. So can we go through a couple of MCQs? Right. So we have a 32-year-old man presented with headache. Right. On arrival, his blood pressure was 190 over 120. So investigations revealed serum potassium of 2.9. Possible causes include. This is sort of a true and false type of. Possible causes include Conn syndrome.
True.
True. Pheochromocytoma. Pheochromocytoma. True or false? So look at the blood pressure. There are two problems: very high blood pressure and serum potassium of 2.9. So do they develop hypokalemia with pheochromocytoma? Yes
No.
or no? No. So that is the answer is false. Cushing syndrome?
True.
True. Renal artery stenosis?
True.
True, because these patients will have secondary hyperaldosteronism, right? Acromegaly? Have you heard about potassium, any association between potassium and acromegaly? No. So then they will not have hypokalemia. So if someone is having high blood pressure, young patient having high blood pressure and high potassium, low potassium levels, you have to always remember three conditions, right? One is Conn syndrome, Cushing syndrome, and then the renal artery stenosis. Right. So shall I read some other? I didn't have time to type all these MCQs. Now you have to carefully listen, right? A 30-year-old woman presented with nausea, abdominal pain, and dizziness for 1 week. And then she has been having lethargy and weakness for a couple of months before presentation, right? So on admission, pulse rate is around 100. Blood pressure, in supine position, it is 100 over 70. On standing, blood pressure is 70 over 50. And basically the rest of the examination is normal, right? Coming with weakness and dizziness. And right. So then investigations done, white cell count normal, hemoglobin normal, PCV 34, platelet count 200,000, ESR 10, right? Random blood sugar 60 milligrams per deciliter. Serum creatinine normal. Serum sodium 180. Serum potassium 5.7. Right? So what is the next step in management? So what is the next investigation you want to do? Serum and urine osmolality, serum C-peptide level, serum TSH, short ACTH stimulation test, urine HCG. So what is the next investigation you want to do? So in the history, so patient was coming with dizziness and all that, right? And patient was found to have low blood pressure and postural hypotension together with low blood sugar and hyponatremia. So what is the diagnosis you are suspecting?
Addison's disease.
Huh?
Addison's disease.
So you have to think about Addison, right? So in that case, what is the next step? What is the next investigation you have to arrange to arrive at a diagnosis?
Short
ACTH stimulation test. So what is the value of serum C-peptide levels? Again, you have to read about serum C-peptide level as well, right? So how to differentiate insulinoma and all that. Okay, and right. So again, a 28-year-old patient presented to the family physician, right, with a recent history of weight gain. Female patient, right, irregular menstruation, and feeling lethargy for 1 year. On examination, BMI is 33 and blood pressure 170 over 100 on repeated occasions. Right? So BMI 33, blood pressure 170 over 100, then there is weight gain, irregular menstruation for about 1 year. Hemoglobin 12.2, white cell count 7.8. Serum sodium 140, serum potassium 3.1, serum creatinine normal, right? Fasting blood sugar 125, total cholesterol 200, LDL 110, triglyceride 150, TSH normal. Right? Investigation by hemoglobin normal, white cell count normal, urine full report normal, potassium 3.1, fasting blood sugar 125, total cholesterol 220, and triglyceride 170, LDL 120. Right? The most likely diagnosis for cause for her elevated blood pressure.
Cushing syndrome.
Cushing syndrome.
Cushing syndrome. So, what about metabolic syndrome? So again, most of the features may be there due to metabolic syndrome as well, right? But this patient's serum potassium is something like 3.1, right? Serum potassium is 3.1. And in addition to that, the triglycerides marginally raised 170, and even LDL is normal, right? And in addition, patient was having irregular menstruation and all that. So the the diagnosis is more towards Cushing syndrome than Cushing syndrome rather than metabolic syndrome, right? So can this be due to Conn syndrome? Unlikely, isn't it? You cannot explain the elevated blood sugar, BMI on all that with Conn syndrome, right? Can this be due to hypothyroidism? Hypothyroidism, some features are there, but usually blood pressure of very high blood pressure is not noted in hypothyroidism, and still not have hypokalemia. They can have a little bit of hyponatremia due to free water retention, right? So again, the important condition you have to remember when it comes to young hypertension is obstructive sleep apnea, right? If the patient's BMI is very high, something like 30 or 35 and all that, and if the patient's ECV value is extremely high, close to 50 or slightly above 50 and all that, right? And if the patient's blood pressure is high, right? With obesity, you have to always think about obstructive sleep apnea because that can lead to hypertension as well. Just wait until I find another. Right. In patients with Cushing syndrome, which of the following features strongly suggest ectopic ACTH secretion? So this is a SPA type of question, right? In a patient with Cushing syndrome, which of the following features strongly suggest ectopic ACTH secretion? Right? Elevated ACTH levels, excessively high cortisol level, glucose intolerance, metabolic alkalosis, refractory hypokalemia. In a patient with Cushing syndrome, which of the following features strongly suggestive of ectopic ACTH secretion?
Refractory hypokalemia.
Refractory hypokalemia. So someone asked question about this hypokalemia. Why is common with ACTH? Right? Probably ACTH will. It's very. I'm not 100% sure how to explain that. Right? But this is one thing you have to remember. If you read your Kumar and Clark, they would say repeatedly say about this refractory hypokalemia in patients with ectopic ACTH secretion, right? And they would say about short history. In Kumar and Clark, it is specially given about very high levels of ACTH levels and short history, loss of weight due to tumors and all that, right? So when something is repeatedly given in Kumar and Clark, those things will repeatedly appear in your common MCQ, right? And then again, you have to very carefully go through the boxes given in the Kumar and Clark, right? So there was a box about the features of so what cortisol can do, like what could happen to the neutrophil, what could happen to the eosinophil count, and all that, right? Simple thing, but again, you have to remember that. You have to go through that, right? And then there was something about glucocorticoid and mineralocorticoid action of cortisol and corticosterone, right? Cortisone and then dexamethasone, prednisolone, right? And then glucocortisone and all that. So glucocorticoid action and the mineralocorticoid action of those various agents. So that again, you all have to go through and you have to have a rough idea, right? And in addition to that, again, you must read about few things about congenital adrenal hyper. When someone is presenting with hypertension at a younger age, how to differentiate congenital adrenal hyperplasia from Cushing syndrome. So again, that is a sort of a self-learning activity which you have to do. Right. What is this? Anyone who has idea about this box, black one? So can you all ask these questions? I cannot actually see.
Sir, it wasn't clear when you were describing the features of pheochromocytoma, the anxiety, those things, it went a bit quiet at that time.
Right.
Would you mind just telling that those few points again, please?
So usually they will have clinical features. The clinical features will come intermittently, right? In episodes, right? So they will have anxiety, palpitations, tremors, right? Headache, flushing, right? And all that as intermittently, rather than they will not have headache throughout. So they can have headache due to hypertension, right? But they will specifically have episodic kind of headache in pheochromocytoma. So in addition to that, they will have episodic palpitations, right? And features the panic kind of situation or anxiety coming as episodes together with flushing, palpitations, and headache, right? So that is a sort of a classical feature of pheochromocytoma.
Okay, sir, thank you.
Anything else? Something has appeared here. I cannot get rid of this. Any other questions? Rather than chatting, can you all ask questions actually?
Sir, sir, before we talk about features such as support ectopic ACTH secretion, where we talk about unprovoked hypokalemia,
Yes.
and all the features occurred in ACTH dependent causes for Cushing syndrome. Is that only for ectopic ACTH secretion?
Now, look at this. Now, there are clinical features where you can have in any cause coming under Cushing syndrome, right? So they will have they can have hypertension, they will have hypokalemia, they can have elevated blood sugar, and all that, right? Having said that, so it can happen due to adrenal carcinoma, tumor, or Cushing's disease, or whatever it is, right? But having said that, hypokalemia is more common in patients presenting due to ectopic ACTH secretion, right? So they will have refractory hypokalemia. So if someone is having features of Cushing's, and if you cannot, if it is difficult to treat hypokalemia, if it is difficult to treat hypokalemia, that is more suggestive of ectopic ACTH secretion. Right? So if they are having very high levels of ACTH, that is more suggestive of ectopic ACTH secretion. Right? Again, diabetes mellitus. So that can be seen in patients with the Cushing's disease or adrenal carcinoma or adrenal adenoma, but more in patients secreting with the ectopic ACTH secretion. Right? So again, if you read this Kumar and Clark, they specifically tell about all these refractory hypokalemia or persistent hypokalemia and all that in ectopic ACTH secretion situations. So those are the things people use when they prepare MCQ papers, right? And so did you get my point?
Yes, sir. Thank you.
Yeah. So any questions? Yeah.
So there's another question. In some MCQs, may the features that appears as Cushing defining features?
What do you mean by Cushing defining features?
In some MCQs, they have given like what are the there were 5 MCQs and there were features, but they asking about Cushing defining features.
So usually during last 10 years, I have gone through all these MCQ papers and all that, usually during exam setup and all that. Right? But I haven't come across something called Cushing defining condition.
It's something like how to differentiate it from simple obesity.
Okay, in simple obesity, so basically then, so if there are features suggestive of Cushing syndrome, so we do overnight dexamethasone suppression test. So there can be positive in patients with who are with excessive alcohol intake and in patients with obesity. Right? To differentiate that from actual Cushing syndrome, you do low dose dexamethasone suppression test. So low dose dexamethasone suppression test will be negative in patients with pseudo-Cushing's. Right? So this pigmentation, again with the alcohol and depression and obesity, patient can have a bit of pigmentation, over palm creases and all that, and things like acanthosis and all that. And they can have truncal obesity and striae, even though it is not really purple. Right? So they can have sort of moon face kind of thing. So those features can mimic Cushing syndrome. By doing low dose dexamethasone suppression test, you can safely exclude that. Right? Anything else?
So in that you have asked about the clinical features that can be differentiate Cushing syndrome from simple obesity. The MCQ appeared as
What are the MCQs which are given? What are the responses which are given?
purple striae, thin
So
skin.
then it may be purple striae. So right, okay, purple striae. If someone is having purple striae, that would indicate that the patient is having Cushing syndrome rather than simple obesity. In simple obesity, they will not have purple striae. Right? So what are the other responses?
Buffalo hump.
Okay, again, buffalo humps is a sort of a buffalo hump is a classical feature of Cushing's, right? Then hirsutism, right? Hirsutism, again, hirsutism can be seen in obesity, especially when it is associated with polycystic ovarian syndrome, right? So hirsutism, it will be difficult to use to differentiate Cushing's from obesity and all that.
Ankle edema.
So ankle edema, again, ankle edema can be seen in patients with chronic liver cell disease and all that. So ankle edema cannot be used to differentiate Cushing's from other causes. The vague symptom, you cannot use that.
So then, in simple obesity, there won't be purple striae.
So usually, when you look at the striae, Cushing's patients will have purple striae, isn't it? And those with the obesity and other individuals will have whitish color striae rather than purple striae. Purple striae is usually seen in patients with Cushing syndrome. So that is what we learn from second MBBS days.
Yes, sir. Okay, sir. Thank you, sir.
Anything else?
Excuse me, sir. So
Yes.
what is the difference between hirsutism and hypertrichosis?
Right. So in hirsutism and virilization, right? Hirsutism and virilization. So you will have clitoromegaly and all that in patients. Especially it is the clitoromegaly, which can be seen in patients with virilization, right? So hirsutism, this excessive hair growth and all that in a male pattern, in a female patient will be there in hirsutism, but the most important defining features would be clitoromegaly. It is seen in patients with adrenal tumors and in patients with congenital adrenal hyperplasia as well. Right? So you should read about this congenital adrenal hyperplasia. So visualization, that is the most important feature. Right. Anything else?
So instead of doing the overnight dexamethasone suppression test, can we directly do the low dose dexamethasone test?
Okay, so again, low dose dexamethasone test, we have to admit the patient, right? And we have to do 2 serum cortisol assays. We have to usually keep the patient for about 48 hours and all that. So in our setup, so that is not a sort of a screening test, right? Screening test is done to find out whether the patient is having possibly having that condition, whether the patient is possibly having that condition, right? So overnight dexamethasone suppression test can be done as outpatient, right? You get the patient to take dexamethasone before going to bed, and next day morning, patient can go to the laboratory and get the serum cortisol checked, right? So that is used to sort of as a screening test, right? So usually we do the screening test, and then if the serum cortisol is adequately suppressed in that individual, so it is not necessary to go ahead with the low dose dexamethasone suppression test. It's like doing when you are suspecting subdural hemorrhage, you should do an uncontrast CT brain, isn't it? Rather than MRI scan or something like that. So you start with the simple basic investigation where you can, if it is negative, you can basically safely exclude that condition, right? Rather than going for low dose dexamethasone suppression test. Usually we start with, because of that, you usually start with the overnight dexamethasone suppression, right? Even if you are asked in a sort of a exam kind of condition, that is what you should do. I would screen the patient with low dose overnight dexamethasone suppression test. If it is positive, then you go ahead with the low dose dexamethasone suppression test. Clear?
Yes, sir. So, what is the place of CRH in Cushing's diagnosis?
I think you all should not go into that extent, right? So even at the postgraduate exam, we don't do that test, CRH and all that, right? So even at postgraduate level, we don't discuss about all these ACTH and this venous sampling and all that. So I think it's, if you're really interested, you can read about all these tests, but those tests are not being done in our setup. So it's not really necessary for you all to know all the details. So I think you must know in and out about ACTH, short synapton test, and then how to combine so short synapton test result with ACTH levels, and then about low dose and overnight dexamethasone suppression test, low dose dexamethasone suppression test, and high dose dexamethasone suppression test, and then how to screen for cons, renin-aldosterone ratio, and pheochromocytoma by checking 24-hour urinary metanephrine excretion. That is not that important for you all, right? So you usually don't do that. Because of that, we usually don't ask those questions at the exam level. Any other questions?
Sir, Kumar and Clark says in high dose dexamethasone test, we need to use 2 milligram instead of 1 milligram.
So different books give different values, right? So don't worry about these 1 milligram or 2 milligram and this thing. What you must know is how to interpret these results. So usually you are given normal values as well, right? Usually you are given normal values as well. So what you must know is how to interpret. Like, so what are the conditions where you have positive low dose dexamethasone suppression test and a sort of a negative high dose dexamethasone suppression test kind of thing, right? So that again, interpretation is important. So that is the most important thing, and at least you must know the names of these investigations. So people will not question about the dexamethasone dose 1 milligram, 0.5 or 2 milligram. That is not really necessary to remember all these values, right? You can always, before daily, you are not going to do dexamethasone suppression test. So you can actually refer a book and find out the actual dose before organizing that investigation, right?
Okay, sir. Thank you.
Any questions?
Sir,
Yes.
Sir,
Yes.
can we differentiate Addison's crisis and normal Addison's disease by investigations only without considering clinical condition?
I didn't get you. Can you repeat the question?
Can we differentiate Addison's crisis and Addison's normal Addison's disease by considering only investigation findings? Without considering the clinical condition.
So, what do you want to differentiate Addisonian crisis from what?
Normal Addison disease.
So, Addisonian crisis means patient has gone into sudden adrenal failure, isn't it? So basically, it's a sort of clinical diagnosis. The patient, when someone is having adrenal failure, right, and so patient is somehow managing, but now the patient has developed fever or stressful condition like surgery, accident, even diarrhea, vomiting and all that, and leading to hypovolemia and all that. So that can precipitate, in that situation, the individual with the adrenal failure will develop adrenal crisis, Addisonial crisis. So that is something pretty much go together, right? So Addisonial crisis is seen in individuals with adrenal failure, and Addisonial crisis is precipitated by acute stressful condition. So did you get that? Did you get the answer?
So normal Addison disease එකනගේ Addison crisis එකනගේ අපි investigations කරොත් ඒ දෙකොල්ලගේ මර degree එක වෙනස් වෙනවා ඇරෙන්න investigation findings එකම විදියට දෙන්නේ.
Yes. So Addisonial crisis. So there is a patient who has actually had, suppose if the patient has got adrenal insufficiency, patient has been having all these dizziness and hypotension and low blood glucose for a long period, but somehow patient is managing. Now the patient has developed diarrhea and vomiting and fever, right? So suddenly the patient will come with low blood pressure, very low blood sugar and all that, all the classical features of Addisonial crisis. Right? The same one is going to depend, this thing is going to develop Addisonial crisis.
Okay, sir.
Right. So any questions? I think that it's almost reaching 2 hours now. I started around 9:45. This automatically will disconnect at that stage. Right? Any questions?
Sir, excuse me, sir.
Yes.
Sir, I have a question about hypoadrenalism, sir. If some patient is present with clinical features and investigation suggestive of, that means electrolyte level are suggestive of hypoadrenalism, the next investigation should be early morning 8 o'clock serum cortisol level.
No. So in that instances, unlike overnight dexamethasone suppression test, we are not going to do serum cortisol levels. Random serum cortisol levels we are not going to do. So I said it's not really, there is little value for serum cortisol level. Right?
So isn't there something called
so in that instance, make a vela vivara veputta vinading cancel way. So in that case, if we are suspecting Addison's, so number 1, we should go for short synectant test. That is the investigation we should do to confirm the diagnosis of primary or secondary adrenal failure. Right? Short synectant test is the next step in management. Right? Then at the same time, we can check ACTH level to differentiate whether it is primary adrenal failure or secondary adrenal failure.
Yes,
It's not 9 AM serum cortisol.
Simply as something like if some 8 serum cortisol 8 o'clock is very low or very high, we can diagnose to safely exclude the.
We can't diagnose. We can't diagnose, right? So we can do random serum cortisol because this synectant test, it is expensive nowadays. This agent is not likely, but in your exam point of view, that is not the test which we are going to do, right? So the next step in management is short synectant test.
Okay, sir. Thank you.
Right? So don't mix up. Right? It's not serum cortisol, random cortisol. Just forget about that. For your information, I gave that this thing, but to confirm nothing else, you have to go for short ACTH stimulation test. Right? Anything else? Shall I conclude then?
Sir,
so almost 2 hours. Right, quickly, Buddha.
Sir, is there any place for sodium levels in Cushing syndrome, diagnosing Cushing syndrome?
No. Usually sodium is within normal limits, right? And potassium will be low. It's about hypokalemia. Sodium level is important in Addison syndrome. they will have hyponatremia and hyperkalemia. Right?
Okay, sir. Thank you, sir.
Cushing's, it is hyponatremia, hypokalemia, low. And Con's disease, Con syndrome, hypokalemia. Right.
Thank you, sir.
Okay, shall I conclude now then? Right, okay. Thank you very much.
Thank you, sir.
Thank you, sir.
Yes, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank
Thank you, sir.
Okay.